Good afternoon, and thank you for inviting me to be part of this wonderful meeting. Today, I will be discussing the management of anejaculation, a subject that is generally not well understood. To be able to manage anejaculation correctly, we need to understand the physiology of ejaculation so we can then understand what goes wrong and what needs to be corrected. For a man to ejaculate, he must first reach an orgasm or a climax. And when he reaches that, then the three phases of ejaculation are activated. Phase one, which is emission, which happens due to contraction of the seminal vesicles, vas, terminal epididymis, leading to deposition of sperm in the posterior urethra. Phase two, which is almost simultaneous, is closure of the bladder neck, which happens with sympathetic stimulation and thereby prevents retrograde ejaculation. And finally, there is phase three. Once the semen trickles into the posterior urethra, there is rhythmic contraction of the bulbocavernosus muscle, which projects the semen antegrade. So failure to ejaculate may happen if any one of these four conditions are disturbed. First, a man may fail to reach orgasm, may fail to reach climax, and therefore there is no ejaculation. Or he may reach orgasm, but there is a disturbance in one of the three phases of ejaculation. So what causes this? Failure to reach orgasm is usually psychological due to psychosexual inhibition, or sometimes due to a physiological problem. And it may happen sometimes, which is situational, or it may be total, which means the man never reaches an orgasm. Phase one disorder, which is failure of emission, may occur if there is a neurogenic problem, as a result of which the seminal vesicles don't contract, or if there is an anatomical blockage due to fibrosis, and rarely due to a hormonal deficiency. A phase two disorder in which the bladder neck doesn't function, again may be neurogenic, or it may be due to an anatomical disruption of the bladder neck. And finally, a phase three disorder, which is failure of antegrade propulsion, may happen if the bulbocavernosus muscle is damaged, or if the pudendal nerve is affected, or if there's a stricture or a pouch in the urethra. So how do we treat this very frustrating problem? First, of course, we need to know what type of anejaculation. Is it situational, in which case, of course, it's purely psychological. He's ejaculating sometimes, but not at other times. Or is it total? If it is total, which means he never ejaculates, then we want to know, does he reach an orgasm but doesn't ejaculate, or fails to reach an orgasm? If he doesn't reach an orgasm, it is anorgasmic anejaculation. If he reaches an orgasm and doesn't ejaculate, it is orgasmic anejaculation. Now, sometimes some men fail to answer this question because they've never reached an orgasm. They'll say, maybe, we don't know, whatever. And sometimes they may actually collect urine or a little bit of urethral secretions and provide that as semen. So if the history is doubtful, another very useful question is, do you have nocturnal emissions? If a man has nocturnal emission, that tells us that there is no physical problem. His problem is not organic, and therefore his anejaculation is due to failure to reach orgasm. So the diagnosis really is quite simple and is made through history. It's only occasionally that investigations are needed. So how do we manage this problem? If it is situational anejaculation, there are a variety of conditions in which this can happen. There may be unexpected failure to ejaculate in an IVF program. And there the vibrator is a very useful tool in helping the man to reach an orgasm. Some men have periovulatory dysfunction that otherwise there's no problem. But when they know that today is the ovulatory day, I have to do it, that is a time when the performance pressure gets to them. Sometimes an erectogenic agent may work. Otherwise, once again, vibrator is very useful. Some men can collect at home, but not in the clinic, and they can be allowed to bring the sample from home. If their home is very far away, then again, they may need a vibrator. Some can ejaculate during intercourse not by masturbation, and for them, non-spermicidal condoms can be used. And finally, there are some who can masturbate, but during intercourse, they don't ejaculate, and that is sexually frustrating. And that, of course, would need extensive psychosexual therapy. Now, if a man has total anejaculation due to failure to reach orgasm, then we have to treat him for anorgasmic anejaculation. And the cause may be psychosexual, severe inhibition, lack of adequate stimulation, or it may just be that his threshold to reach an orgasm may be very high. So it is possible to sometimes treat these men with psychosexual therapy, but often the treatment is long and not successful. And I found that vibrator therapy is far more effective. It will work right away in 60–70% cases, sometimes at the very first visit itself. So how do we use the vibrator to treat anorgasmic anejaculation or even for situational anejaculation? The principle is to apply a strong stimulus, vibratory stimulus, to the undersurface of the glans penis. And this will, because of the strength of the vibration, overcome any psychological inhibition, help the patient to reach his physiological threshold, and thus reach an orgasm. So in a room with privacy, with no disturbance, the man is asked to fantasize, relax, get aroused, and then he uses one of various types of vibrators available to stimulate the undersurface of the glans, which is the most sensitive area around the frenulum. And he's told not to try to ejaculate. That is counterproductive. He's told to relax, fantasize, apply the vibrator, and just let things happen. And sometimes he will ejaculate in 10 minutes. Sometimes it may take 1 hour. Sometimes they may succeed at the first session. Sometimes they may need 3 or 4 sessions. If they do succeed, they can continue at home with the vibrator, and many of them learn to ejaculate naturally. Others will collect a sample with the vibrator and inseminate their wife to achieve a pregnancy. If the vibrator doesn't work, there is electroejaculation, but this is a very expensive device available in very few centers and generally therefore not accessible to most people. If there is orgasmic anejaculation, then the treatment will vary according to the cause. Sometimes failure of emission or retrograde ejaculation due to a neurogenic cause will respond to a combination of a sympathomimetic drug with an anticholinergic. But in a large number of these cases, medication doesn't work, surgery is not helpful, and they wind up having a sperm aspiration followed with an IVF ICSI. So depending on the cause and the phase and the condition, we have to find different solutions. So to summarize, anejaculation may be situational, which is psychological, or total. Total may be anorgasmic or orgasmic. Anorgasmic is again psychological. Orgasmic is always organic. 2 key questions: do you reach an orgasm? Do you have night emissions? And that would help with the diagnosis in many cases. The vibrator is perhaps the most commonly used device to treat these patients, and everyone should have one. The majority will respond to the vibrator, but there will be 20–30% who will need more advanced therapies, either in electroejaculation or sperm aspiration and IVF ICSI. Thank you very much for inviting me to be part of this meeting, and I'm now available